Minister. I'm Bernadette. I'm the National Data Programme Lead for VCHA. Ed, you've heard introduced, is our analytics partner. He's going to start off by telling us a little bit about what we're seeing so far in terms of the data that we've looked at, and then I will take over and tell you about where we are and where we want to go next.
Perfect. Thank you, Bea. So we heard Tim and Kate talk about the importance of data evaluation and understanding the impact of the programmes that the VCHA is involved in. So we're going to spend a bit of time talking you through how Bea and I are supporting the VCHA on kind of understanding its impact and its journeys to kind of try and improve the data that's used to guide decision making. So I'm going to begin by talking about work we're doing evaluating the overall impact of the VCHA. That's a really important piece of work for the VCHA, partly because VCHA needs to demonstrate that it's a programme that's delivering value for money, but also the evaluation is an opportunity to look at what's working well, what's working less well, and kind of looking at that evidence and working out which of the bits of the programme that we can turbocharge and do more of, and where are the things that we need to start trying to do things better. Not wishing to sort of spoil the punchline on this, but one of the things that we're finding from the evaluation is the importance of data. It's very hard to get consistent data on armed forces personnel accessing health services. And without that data, it's very difficult to understand what's going on and therefore what you need to do to drive change. So I'll show some data on that shortly to evidence why I think that's a really important focus for the VCHA going forward. And then Bea is going to pick up towards the end just to talk about what we're doing to try and really get some momentum behind a programme to try and deliver more consistent data to understand how veterans are accessing healthcare. So first of all, on the evaluation, you'll see down in the blue boxes on that slide all of the Veteran Aware accreditation standards that you'll be well aware of. What we're trying to do in the evaluation is two things. We're trying to understand, first of all, what are the difficulties that trusts are working through when working towards those standards? How is the VCHA supporting that? What's working well? What's working less well? But we also want to understand for organisations when they meet those standards, what sort of initiatives is that then enabling? What are the programmes that they're able to deliver off the back of meeting those standards that is making a real impact on the care and the journey that veterans are receiving as they pass through the health system? We're collecting our evidence base on that by doing lots of interviews. So some people in the room will have been harangued by members of my team to provide evidence and data for those interviews. We're doing a national survey of armed forces champions to understand their roles, what's working well, what's working less well. We're collecting case studies. We've heard about some of those today. And we're going to try and look at trends from data in organisations that are taking part in the programme. The evaluation is due to report in January 2026. So it's quite a long programme of work. The reason it's long is we want to collect some initial evidence now, take that back to the VCHA leadership team, use the findings for that to say what are the tweaks and the things we might want to do differently going forward. And then there's an opportunity to come back over the coming 12 months to kind of see if we've made a difference by learning from the things that are not working so well. And in terms of the themes that are coming out of the evaluation so far, so this is sort of early themes based on interviews we've done. I mean, on the positive, there is a lot of positivity about the focus and the recognition that working towards the accreditation standards brings. It shines a spotlight on the importance of veteran health within services. So there's lots and lots of positivity about the programme and the activities that it enables. But it's not always a particularly easy journey. So three things that have been highlighted as areas that armed forces champions in particular are struggling with is, first of all, it's quite hard to push forward the accreditation work when it's kind of a bolt on to your existing day job. Sometimes staff will be part-time. So it's just sort of protecting time to really drive the journey that the armed forces champions want to take their organisation on is just difficult when it's kind of a bolt on to the day job. And I think there's tools and things that the VCHA could help with to help armed forces champions on that journey. Second, there's quite a lot of variability, I would say, in the feedback we were getting on the level of executive support and buy-in for what the VCHA and the accreditation programme is trying to do. That's not to say that organisations weren't supportive, but busy executives have got lots and lots of different priorities in the NHS at the moment. And in organisations where leadership was fully behind and committed to the work of the VCHA and the accreditation, it made a real difference to what the Armed Forces champions are trying to do in those organisations. And the final area, which I think touches a little bit also on what Linus was talking about, is just getting overall organisational wide awareness of armed forces health and the programme and the benefits of meeting the accreditation standards. There's just a lot of work that needs to be done to kind of increase organisational awareness training, making sure staff are aware and so forth. So all areas where we can help. And the final thing that was a big challenge that came out in the data is just in the interview, was data to understand and drive change. So at the moment, there is no consistent data set that allows us to understand the journey that armed forces personnel are going through when they access the NHS. So that means when you're sitting down and looking at variation in services, you're not really dealing with data, you're dealing with anecdotes, you're dealing with perception. And that's really difficult. But what we've learned through programs such as the GIRF program is once you start to collect consistent data, you can begin to challenge that preconceived wisdom. You're no longer working with anecdotes, and you can use that data to have one version of the truth, coalesce an organisation about this is what the data is telling us, and that gives you a platform for then jumping off, doing something about it and tracking change. And just to underscore the importance of the data, I'm not going to go down a data rabbit hole here, so don't worry, but I just want to show some data that we collected during some pilot work with trusts that shows the variation in the experiences that armed forces personnel have when they're accessing health services. So we collected data from 6 trusts in a pilot programme. This is just one example metric that came out of that work. So this is looking at veterans who are an inpatient, and it's looking at, for those veterans that are inpatients, what proportion of them got into that inpatient bed through the emergency department. So you'll see in Trust 3, for example, you're much more likely to be in an inpatient bed because you come through the emergency department than perhaps it's been a more planned journey. Whereas in Trust 4, it's much more likely you had a sort of more planned route to ending up in that inpatient care. Now, I would look at that variation and I'd want to understand, well, what's going on in Trust 3 versus Trust 4? Is it something to do with the way that primary and community outreach services are working with veterans? Is it just something to do with the way that veterans are engaging with acute services? I can't tell from that, but I'm pretty sure there's some really important stories behind what's driving that sort of variation. Similarly, this chart is looking at, if you are the veteran, that inpatient, that emergency admission in the inpatient bed, how long are you staying there? And again, we see wide variation across the trusts. Could be driven by case mix, could be something else, could be to do with discharge pathways. I can't tell from that, but again, I'd really want to understand what's driving that variation and what can we do about that. We can't do that at the moment with the data we've got. This chart's looking at data from the DMWS. They collect data asking veterans about their improvements in wellbeing once they've had a contact with a health service. And again, you see big differences there in terms of veterans reporting that their wellbeing has improved post-referral. So again, some huge variations in there that I'd want to be digging into. And the final one, we've compared the veteran population to the non-veteran population in this chart. So this is looking at length of stay for veterans that are admitted through emergency departments versus the general population. And again, you see differences in length of stay for veterans versus non-veterans. So again, some really important differences that I would want to dig into, but at the moment we're not collecting and flagging armed forces personnel in a consistent way to allow us to really get a handle on that. But my colleague B has a plan that I hope will begin to start to address this to allow us to collect more consistent data. It's a bit of a bumpy journey, not wishing to spoil the punchline, but I'll let B talk more about that.
Yeah, it's been interesting today, hasn't it? We've learned lots, we've heard from lots of people, all in different settings and different roles. We didn't actually plan this, but everybody who's spoken before has set this up beautifully for me, because there are some, you may have noticed, some recurring themes that we're coming across that are proving to be difficulties for everybody. And a lot of them are related to not knowing our population in enough detail. We don't have that rich, accessible data in order to make our interventions the most effective that we can. So we are trying. So where are we? We have lots of data in lots of formats, in lots of different places, lots of different sources. What we don't have is a definitive, standardized, validated and easily accessible source that we can all use for our planning, and even at a really basic level to know to make a meaningful needs assessment, care plan, discharge plan. We don't have that facility available to us. We've heard a few people talk about the NHS 9 commitments, NHS England 9 commitments in the long-term view and the forward plan. I've just put one of them up there. Several of them relate to data and how we need to use a formal process to make our jobs easier, but also more effective for the people that we're trying to help. We, as Ed said, we did a small but quite successful and helpful pilot around data last year in partnership with Edge and indeed with DMWS. As we always do, we reported on that, we came up with a set of recommendations. And the key one for us is around establishing that core national standardized consistent data set that we've talked about so that we can all use effectively. So we need that so that we can actually meet our vision and aim. And we're all in the room for the same reason. We want to improve access and outcomes. That's as individuals. It's also our statutory obligation in terms of the Armed Forces Covenant. So if we don't have the information to know our population, we can't actually do that. So what are we doing? We're doing quite a few things, actually. Ed's alluded to it, not entirely straightforward. You won't be surprised to learn, for all sorts of reasons. People have different IT systems. Some people are able to access and retrieve data much more easily than others. It's not an even playing field in that sense. But we have a real goal, and I think it's a really important, it's exciting, and it will be, not to be too dramatic, it will be transformational once we get it in place. So we're working with the Outcomes Registry Programme, or ORP, that nifty little abbreviation that we always use. You may not be familiar with it. If anyone works in orthopedics, you'll probably know it because this is where NJR, or the National Joint Registry, has sat for quite some years. We're working with Edge and indeed DMWS, and I'll explain that connection in just a second, to establish exactly what we've been talking about, a specific, dedicated armed forces registry, so that we can get that rich and meaningful information to make the change that we want to change. Before everybody panics and says, oh God, no, not more reporting, I promise you, when this is set up, it's not additional reporting. There is one thing which I will leave you with in a second, which is crucial to it. So the DMWS bit, people in this room will know DMWS are incredibly effective, particularly at getting feedback on outcomes. NHS is not as good at collecting outcome information as we are collecting activity, performance, numerical stuff, if you like. So we're working with DMWS to work out how best to capture useful outcomes data. In terms of setting up the ORP registry, we're in the early stages. It is, as you would expect, a robust governance process to get through, not least because if we're asking people to tell us about their armed forces status, we have to protect that information, and you would expect us to do that. So there's a fairly lengthy and robust governance process to go through, and we're in the early stages. So our next steps are to complete that governance process. I've talked about the outcome measure and how that's less straightforward. We are working with GMWS. We've also, and I've talked to Nikki about it this morning, we will work with patient groups to get some advice on what are the meaningful outcome measures for people who are using the services. So that's a kind of parallel work stream. There is a further parallel work stream our comms colleagues are helping us with. And this is the bit I want to leave you with, because if we don't have this bit, we can't do anything that we've been talking about. So what I want to leave you with is, when you go back to your organisations and indeed your wider networks, please encourage them to ask the question. Because if we don't know armed forces status, we can't measure anything. So that's what I want to leave you with. Thanks very much.